Okay, good afternoon and welcome to the afternoon part of the conference. I hope you've all filled your bellies and feel like your brain has been regenerated with some energy. So we're going to start the afternoon session. So I'm just going to hand over to Professor Rob Moots, who's going to introduce the first afternoon speaker.
Thanks. Well, welcome back, everyone. And again, welcome if you're joining us online. If you're watching live, it's good to see you. If you're watching on a pre-record over a glass of wine, cheers. Everybody's heard that joke earlier on, but they're still laughing at it. Just out of politeness for me, I think. Anyway, three great talks this session, then we have a coffee break, and then more great talks afterwards. But three important aspects of BEHÇET'S we're covering today: joint pain, psychological aspects of things focusing on fatigue, and then we'll finish this bit of the session with a crucial symptom that people tend to get a lot, which is headaches. So for the next speaker, it's a pleasure to introduce Dr. Jagdish Nair, who's consultant rheumatologist at Aintree and one of the consultants in the Liverpool BEHÇET'S Centre. And he's going to be telling us about joint problems and BEHÇET'S. Jagdish.
Good afternoon. Thank you for inviting me to speak on joint pain. I apologize if it is oversimplified, but if you have any questions, you could ask me. So there are lots of causes of joint pain in BEHÇET'S, and as you know, it's one of the commonest manifestation of BEHÇET'S disease. Up to 90% of people who attend our clinics may have joint pain, and there will be a variety of reasons why people have joint pain. So I'll try and list some of the causes of joint pain during the talk and the details of it and how we assess and what can we do to manage them. So as you can see, these are the things which we see commonly in BEHÇET'S. The inflammatory arthritis, which means inflammation in the joints. Sometimes it's inflammation in the tendons or ligaments which attach to the bones. These are called enthesitis, although it's not very common, and sometimes sacroiliac joint pain. I'll come to the details as I go through. Then some people may have mechanical pain. That means it's due to the mechanics around the joint. So it could be a degenerative joint disease, or it could be due to the tendons and ligaments around the joints which can cause pain. And the last one is chronic widespread pain or fibromyalgia, which causes widespread pain, which we don't understand very well. So, as I said, 90% of people may have joint pain, but actual fact is that only 20 to 50%, depending on the population you see, have inflammation in the joints. So when I say inflammation, it is kind of a group of symptoms and signs, which means you may have an arthralgia or joint pain, or you may have a joint swelling. There might be local heat. So when you feel the joint, it may feel hot. One of the things is that if you feel it's hot, it's cold, you compare, for example, you have knee pain, you compare both sides, and one might be a little warmer than the other. So it's still a hot joint. And you may have inflammatory stiffness. That means the stiffness which worsens, which improves with activity. So most of the non-inflammatory stiffness, it worsens with activity, as you would see with sometimes osteoarthritis. So people will have pain and stiffness for an hour, half an hour and more, but as you do activity as the day goes on, it will improve. So that is a sign of inflammation. Now, in terms of how this joint pain can manifest, so some people may have pain and swelling in the joints, which may be lasting for a few days to a few weeks and settle. And some people may have persistent joint pain and swelling, which continue to get worse. Depending on the number of joints, we also classify as monoarthritis, which means one joint is affected. And in BEHÇET'S, mainly, one large joint can be affected commonly than others. And particularly, we see a lot of inflammation in the knee joints. Oligoarthritis means 4 or less joints, which is also sometimes seen in BEHÇET'S. Polyarthritis is multiple joints, which is slightly less compared to the other numbers I said. Now, the important thing to remember is the inflammation in bedsheets is non-destructive usually. That means it does not cause erosions or destruction of the bones. Unlike rheumatoid or psoriatic arthritis. In lupus as well, similar to bedsheets, we don't see inflammatory damage to the bones. Then the other thing is, very rarely, as with anyone else, you can get also septic arthritis, because we put people on a lot of immunosuppressive drugs which impair your immune defenses against infection. There can be a risk for septic arthritis, although we don't see this much in our clinics. And septic arthritis can manifest with intense pain, inflammation, and it's quite difficult to treat. Sometimes the damage can be done within a few days. So you have to have a multi-pronged approach to managing septic arthritis. And thankfully, it's very uncommon in bedsheets. And reactive arthritis is something which is, as you may have heard, it's a reaction to something else happening. So most commonly, it's an infection which triggers off. So for example, somebody has a diarrhea, somebody has a urinary infection. Your body perceives this as an insult and tries to attack through immune mechanisms. And one of the target for the body's defense mechanism is the joint. And people can get inflammation and with swelling in the joints, very painful condition, can last for days, weeks, or months, and then get better. And very rarely, because some people may have a tendency to get gout. So for example, if there's an underlying disease like the kidney disease, chronic kidney disease, or diabetes, when there are triggers of stress, then people can get gout as well. And a lot of can also depend on your body habitus as well, like increased weight. And sometimes any stress can induce pseudo-gout. A gout-like presentation means very severe pains, swelling, and redness in the joints, which may last for days or weeks. As I said, enthesitis and sacroiliitis is very uncommon in bedsheets. There was a time when bedsheets was clubbed with other seronegative arthritis like ankylosing spondylitis, but it came out of that group classification. So enthesitis means where your tendons and ligaments attached to the joint, it gets inflamed, swollen, and tender and painful. The most common sites we see in our clinics is the hips. People may come with what we call the trochanteric bursal pain, but it's not actually bursitis, it's actually enthesitis, which means that your buttock muscles or gluteal muscles insert into your hips, and that area becomes very inflamed. Now, this is not very common in our clinics, but in certain countries where there is an acne arthritis clusters, or as you know, bedsheets has got different manifestations. Some people may have vascular bedsheets, some people will have acne arthritis type clusters. So in those clusters, this enthesitis is common. Other areas where you can get inflammation in the enthesis, when I say enthesis, where the ligaments and tendons attached to the bone, are the front of your knees, below your kneecap, below the patella. And the other area is the ankle, and also you can get plantar fasciitis. So these things can be present as a manifestation of bedsheets. Sacroiliac joint is very uncommon. We occasionally see people who have inflammation in the back of the spinal joints and sacroiliac joints, but not very common. The other thing is mechanical. As I said, people can get, in simple terms, wear and tear of the joints. You can get osteoarthritis, and it can be seen in any of the joints, but mainly in the large weight-bearing joints. Now, as you know, fibromyalgia is common in bedsheets. Again, we don't understand this condition very well. There might be reasons why people get fibromyalgia. There's a good association with inflammatory disease like bedsheets or rheumatoid arthritis. But sometimes there's no reason. And sometimes this can cluster in the family, as gene association studies have shown that sometimes due to certain genetic predisposition, people can get. And there can be a trigger for it. So the triggers can be psychological stress, but mostly it's associated with a disease, inflammatory disease, but sometimes it's a standalone problem. Now, physical stress is not thought to be a very big trigger of of fibromyalgia. And also we don't think infections are a big trigger for fibromyalgia. So people will feel pain all over. They are tender. They have may associated symptoms like fatigue. One of the common things are headaches and sleep disturbances. I'm sure that you will have a talk later about headache and fatigue. So it could be explained. Some people may have cognitive associations like depression, anxiety. Now, I thank all the people who participated in the study we did in Aintree. We looked at fibromyalgia in our patients, and we found that pain was a very common association, and with active disease, the scores were high. What we understood from this study is that people don't always complain of the stress and anxiety and depression, but this was, and it's maybe that people don't complain, or probably that we don't ask it much, but people do have a lot of cognitive issues, and thankfully we have the psychology service, and Dr. Crozier might talk about it, which is helpful an intervention to improve pain. So I'll quickly talk through what we do. So if you have a problem with your joints and joint pain, please speak to your doctor, a rheumatologist, your BEHÇET'S consultant. And we take a history. We assess the joints to look for swelling and any inflammatory features. And there are investigations which we can do. I know the pointer may not be seen by people in the online audience, but if you do an X-ray, you can see sometimes the damage. As you compare this side to this side, there's loss of joint space. We can assess the joints when it's not very clear. If people are complaining of a lot of pain and swelling, and it's not very apparent on clinical examination, ultrasound can be done in clinics or in the hospital. Some rheumatologists do, some don't do, and you can scan the joints or the enthesis, and you can see all these red spots, which are increased inflammation or increased blood supply in the tendon and joints, and this is suggestive of inflammation or tendinopathy. Sometimes we'll have to do MRI scan because these joints are not easily accessible, and we can, as you can see, these white areas in the sacroiliac joints on an MRI scan, so it proves that there is inflammation. So there are lots of modalities which you can do to reach the conclusion as to why you are experiencing this pain. So how do we manage this? So as I said, always speak to your doctors to see how we can find what's the problem. And there is no single approach to managing. You have to have a multi-pronged approach to managing pain in BEHÇET'S. So if you don't have any problems like gastritis, chronic kidney disease, or heart disease, then you can have some anti-inflammatory drugs. It could be like Brufen, naproxen, or it could be paracetamol and codeine for the shortest period of time to control your pain symptoms. Sometimes we may have to inject that joint with steroids. That might be a useful intervention. And if you have an inflammatory arthritis, most often you will need a disease-modifying drug. And now for joints, you can have colchicine, or you might have to escalate to something like methotrexate or azathioprine or mycophenolate, or sometimes biologics such as anti-TNF drugs. And they are very, very effective in treatment. But in isolation, it doesn't work. You have to have other input like physiotherapy, keep the joints moving. And sometimes you might need splinting and other orthosis to help to improve the pain and improve the function. For degenerative type of arthritis, some of these interventions, the immunomodulatory drugs don't work. So for that, it's analgesia and physiotherapy and occupational therapists. So those kind of things. Keep moving is the mantra for improving the joint problems. As I said, we don't understand chronic widespread pain or fibromyalgia very well, so we don't have any major pharmacological intervention for this condition. So the important thing is activity. So graded activity. Don't do too much in one go. Gradually build up what you can do. Then the interventions which have shown to be somewhat effective is aerobic exercises. Strength training can also improve pain. Overall, these exercises can improve the well-being the feeling of well-being. That's the most important factor. And then, as I said, one intervention does not work in isolation. You have to have multiple interventions to improve. So in terms of managing pain, the drugs don't work. So pain management programs in certain centers are useful. Cognitive behavioral therapy is useful. So all interventions coming together can improve your symptoms. And also, not just coming to the clinic or seeing within the clinical or hospital setup, you also need support within the workplace, so workplace adjustments. And we do write letters to support workplace adjustments when requested. So that's my talk. I'm happy to take questions. Thank you.
We'll take questions afterwards, unless anybody has a really burning question for Dr. Nair. There's a couple of questions that have been coming through, and I've made a note, and we'll pick those up a little bit later. So thank you for that. It's very important, joint pains, and we move on from joint pains to an equally important issue, which is fatigue. I would be very surprised to come across somebody with BEHÇET'S who has not experienced profound fatigue, and it's a very difficult issue to talk to people about because you can't see fatigue, and it's a very difficult problem to manage. So it's great that we can hear from Suzanne Crozier, who's our clinical psychologist at the BEHÇET'S Centre, who's going to say a little bit about that to us now. Suzanne.
Hi, it's nice to be here today. As Professor Moot said there, I'm Suzanne Crozier. I'm the clinical psychologist at the Liverpool Centre. Just get my talk up. Okay, so yeah, I'm going to be talking about fatigue in BEHÇET'S today. Just to give a little bit of background to the link between BEHÇET'S and mental health, first of all, we know that from what we see in the centres and from the research, long-term conditions like BEHÇET'S are generally associated with higher rates of anxiety and depression and reduced quality of life. Some of the reasons that are a bit more specific to BEHÇET'S about why that might be the case are that it's a rare condition which can add to feelings of being socially isolated. The route to diagnosis can be long and complex, although the length of time to diagnosis has reduced since the centres have been commissioned. We know that for a lot of people, that process can still be quite long and complex, which again can add to distress. I think as has been mentioned in some of the earlier talks, it's an invisible illness, so a lot of the symptoms like chronic pain and chronic fatigue aren't visible to others, which can make it hard to communicate about the impact of those symptoms on people, which again can add to the burden of living with the condition. And the symptoms are often unpredictable, so with it being a remitting and relapsing condition where symptoms tend to flare up, that can lead to uncertainty and difficulty in planning ahead, feeling a sense of control over things, and it can impact significantly on work and social life. So there are some of the aspects that are a bit more specific to BEHÇET'S, which can make it a challenging condition to live with. So I wanted to talk about fatigue in particular today because it is a symptom that, as Prof said, most people will experience at some point in their journey with the disease, and it's often cited in the research and also in clinic as having the biggest impact, along with persistent pain, on people's quality of life. So in the talk today, I wanted to give an overview of the nature of fatigue, some of the causes of fatigue, and some ideas about how we can manage it. So starting with a definition of what is chronic fatigue and how is it different from normal tiredness or fatigue. So this is from a study in 2019 on chronic fatigue, and they define it as a severe physical, cognitive and emotional exhaustion that can interfere with a person's usual daily activities. It isn't typically relieved by common strategies that restore energy. So if we break that down, we've got the physical aspect of feeling exhausted physically, but we've also got the cognitive aspect, so our ability to think clearly, to remember, to pay attention, to concentrate. Some of those cognitive aspects can also be affected by fatigue, so people will often talk about finding it hard to think clearly or a sense of brain fog. It's very common. The emotional exhaustion, so flattened mood is common as well. It can have a significant impact on day-to-day life and what's energy is available to do activities, and it isn't typically relieved by things that we might expect fatigue to be relieved by, such as rest and sleep. So people often talk about having had a really good night's sleep but still feeling unrefreshed in the morning. These are a couple of quotes from a study on fatigue, and this is patients' sort of description. So, a complete drain of energy, very different to being tired. It's like somebody stuck a syringe in you and sucked all the energy out. Some days the brain fog is so bad that I can't have conversations, find the right words, remember names or things. So again, we can see there's the physical aspect of the feeling of exhaustion, but there's also the cognitive aspect as well, which I think sometimes people don't necessarily make that link with fatigue and the effect on cognition. So going on to look at some of the causes of fatigue. It can be helpful to differentiate primary fatigue to secondary fatigue. So primary fatigue is thought to be caused by the disease process itself. So in Behçet's, that would be the inflammatory process. Whereas secondary fatigue is a lot of the aspects of living with a condition like Behçet's. So things like the emotional distress associated, which we've mentioned, chronic pain, which in itself can be very fatiguing to live with. Sleep disturbances are very common, side effects of certain medications which can contribute to fatigue, activity levels, whether that's inactivity or overactivity, things like infection, quality of diet, and also environmental factors, so things like temperature, lighting, noise, all of these individual factors can again contribute to fatigue as well as the disease process itself. And this is where in clinical health psychology we often draw on the biopsychosocial model to try and understand health symptoms and their management. And this is to demonstrate that we're not just looking at the biological aspects of a disease, we're also looking at the psychological aspects, so the impact on mood, stress levels, individual ways of coping, personality styles, and the social aspects. And this is where we work closely with the patient support coordinators across the centres to address some of these social aspects, which are really crucial in how well somebody's able to cope with living with a long-term condition. And these are things like how much support is available to a person, what are their individual family circumstances, how much support might be available in the workplace in terms of reasonable adjustments or in education, because all of those things can again contribute to how successfully someone can manage their condition. And it's to get a holistic sense of the person really, so we're not looking at any of these one areas in isolation. In order to fully understand how a condition is impacting on a person, we need to look at the broader picture. And we might wonder why the mind is important in this. So when we're thinking about a symptom like fatigue, which might seem quite biological in its nature, so this is an example of how, it's just a very simple example, it's often more complicated in practice, but if we take a situation, so the house might need cleaning for instance, and if a person experiences the thought, I should be able to do this like I used to, I need to get it done, that might lead to emotions of feeling determined to do the job, but also feelings of frustration, maybe a change in activity levels, what's possible because of the impact of fatigue. It might lead to feelings of guilt or shame that they're not able to function as they used to. That in turn might create a stress response in the body, so we might notice heart rate, breathing rate increases, feeling hot and tense. And these things might combine to then create a behaviour. So in this example, it might be that the person tries to get the job done, tries to keep pushing even when they feel tired or in pain in order to get the job done. And in turn, that could then create an increase in fatigue. So we might see a crash in energy levels or an increase in fatigue following that. And some of the thoughts that I often hear in clinic when we're talking about fatigue are things like, I won't let it beat me. If I can just keep going, they might find a cure or might get better. I can't do anything like I used to. This isn't going to get any better. And we might be able to see how some of these different thoughts might create different emotional responses and different behaviours for the individual. And moving on to the boom and bust cycle, this may be something that people have seen before and it's used quite a lot in fatigue management. And the idea here is that when people have a bit more energy available, so a day where the fatigue might not be as severe, understandably, people might try to get more done, so they want to make the use of having that energy, so they might push themselves, maybe be a bit more active, which is where we get the boom in activity levels. And often that's followed by a crash in energy or the fatigue becoming worse afterwards, which is where you get the down bit on the graph. And if that is continued over time, this boom and bust, we can actually see an increase in fatigue or a reduction in energy levels over time. And that's often something that we want to help people identify and address if that's relevant. I'll go on to say a little bit more about how we do that. So how can psychology help with something like fatigue? So we have a range of talking therapies that we might use in health psychology, and often we're looking at helping people to manage problems like adjustment to diagnosis, and that's not necessarily just at the point of diagnosis, that can be at any point in the journey, because often adjustment is an ongoing process. We might look at particular mood problems like anxiety and depression, or symptoms like chronic pain and fatigue, and often it's a combination of lots of these different factors. So we offer a listening space, a space to process the impact of living with a health condition like BEHÇET'S, education and sense making, so helping people to understand how their fatigue and activity and energy levels interact and affect them, how it links to their mood and their day-to-day lives. And ultimately we're trying to help people learn their illness and learn their condition. What are their patterns, what are the triggers, what helps and what doesn't help for that individual. And specific to fatigue, some of the interventions that we might use are things like pacing or energy conservation, it's sometimes called. And that's where we're helping people to monitor activity, fatigue and mood levels over time, and helping people to try and address that boom and bust cycle if that's relevant for them, to try and plan activity consistently where possible, which can sound simple and it can be quite straightforward, but it's actually quite challenging for people to implement, because it might involve adjusting their day-to-day lifestyle, or kind of accepting that fatigue is there, and it can be managed but might not completely be curable, which can be understandably emotionally challenging. So alongside that, we're often trying to help people identify their personal values, what's important to them in life, so that they can try and plan and prioritise activities in line with those values, rather than trying to be under pressure to achieve or do absolutely everything. And ultimately, we're trying to help people increase a sense of efficacy or control, so that they don't feel controlled by symptoms like pain and fatigue. So this is going back to the cycle that we looked at previously, with the role of thoughts, and the bits in red are some of the ideas for interventions we might use in this particular example. So we might look at helping people to learn strategies to manage unhelpful thinking. We might look at building up awareness of emotions and mood. We might look at teaching skills like mindfulness or relaxation to address the stress response. Or we might look at more practical strategies like pacing, breaking down tasks, or asking for help, and the more sort of fatigue-specific strategies. And just to mention about self-compassion, so we know that for people living with symptoms like chronic pain and fatigue, they can have a really significant impact on life and activity, what's possible, and that can sometimes lead to changes in self-esteem or identity for people. It can lead to self-criticism or feelings of shame, or feeling isolated and different from others sometimes. So therapies like compassion-focused therapy can be helpful there in directly addressing things like self-criticism or feelings of shame, and learning strategies to manage those things. And we often see a relationship between improved self-compassion and improved ability to implement strategies like pacing and improved adjustment. And at Liverpool, we're involved in a study at the moment that's looking at levels of self-compassion and the relationship between self-compassion, fatigue, pain and mood in BEHÇET'S. So we'll be interested to share the results of that over the next year. So in summary, fatigue is a multifaceted symptom in BEHÇET'S, and it can have a significant impact on people's lives. But hopefully through a combination of medical treatments available, lifestyle modifications, along with psychological and social support, and fatigue management strategies like energy conservation or pacing, we can help patients learn to manage fatigue or adjust to living with fatigue more effectively. But as with lots of things, ongoing research and education is crucial to developing better strategies in what is a challenging aspect of living with BEHÇET'S. And I've included here some self-help resources that people might want to refer to find out more about chronic fatigue, as well as compassion the Compassionate Mind book and mindfulness, as well as pain. And there's a couple of websites there as well which have got some resources available and information. Thank you for listening.
Thanks, Suzanne. Very important issue here. So Suzanne can't stay for the Q&A session, but she's finished with a few minutes to spare, so she'd be very happy. Well, she's going to.
I'm smiling.
Politely take a few questions, because fatigue's such an important thing. There's one question that's come through from patient. They found that taking coenzyme Q10 has been really helpful for their fatigue. Is that something that you're aware of, or if not, are there any kind of medical things that can be useful? I know we failed medically in many ways of that, but what do you think, Suzanne?
Haven't heard of that particular Q10. No, I don't feel like that's something I'm aware of, but I don't know if anyone else here have heard of that. But I guess it's finding what works for the individual, isn't it, and anything that's helped.
Do you think that one of the kind of issues is that people don't really admit to being fatigued? Some people do, but some people don't. Do you get the sense, Suzanne, there's a lot of people struggling with fatigue and just don't know what to do because we can't see it? The partner might not really be very sympathetic and things. How do you approach that?
Yeah, absolutely. I think it is definitely a symptom that is invisible and can be hard to communicate about, because a lot of people feel under pressure to just keep trying to push through, trying to keep going. There can be a lot of guilt associated with, the reduction in activity levels or what's possible day to day. So I think it's a tricky subject to communicate about, particularly because a lot of people haven't had that experience of chronic fatigue, and it is very different to tiredness. So a lot of the time it's hard for people to understand how it might impact on the person, and that's the sort of conversations we often have with people, is about how to communicate the impact of a symptom like fatigue, because it can be extremely challenging to sort of adjust to.
Because I can pretty well guarantee that anybody here with BEHÇET'S will have or will have had fatigue. So if you want to ask a question, please do go ahead, because everybody else will sympathise with the question that you're asking. And if you're not totally comfortable about speaking out loud, don't worry about it. But if you're not, write it down on a piece of paper, because we've got a few more minutes before we can let Suzanne go. Suzanne's going away on a family holiday, so that's why she has to escape, and it's just really kind that she could come along and share all this with us today. So she will be thrilled if there's any more questions. So have a think, write it down, let Gemma know. Yeah, over there, Gemma, gentleman there. Good lad, well done for putting your hand up. You're my favourite now for asking the question.
Yes, thank you so much. That was a very helpful presentation. But I did want to ask if there are any lifestyle or diet or things that we can do to contribute to, obviously acceptance is a huge part of it, but is there any control or things that can help along the process, or things maybe to avoid as well that can help with the fatigue?
Yeah, I think the sort of the pacing is often one of the main strategies that we use in fatigue management. So trying to recognise where people might be feeling that pull to keep pushing through symptoms, sort of not wanting to give into it is really common. So trying to keep going, keep pushing through, and then sometimes getting that crash in energy levels afterwards. So that's often the first thing that we're trying to help people look at, if that's happening, to try and address that differently through things like pacing, so that you're planning your activity over time to be used more consistently and avoiding the boom and bust in activity levels. In terms of diet, it's not my area of expertise, but I think things like just following sort of healthy sort of eating guidelines, avoiding things like excessive caffeine, especially late at night, because that can impact on sleep and things. So sleep's another big one. Sleep disturbance is really common, so that might be something that we work on specifically with people as well, to try and improve sleep patterns, sleep hygiene, that kind of thing, trying to understand what might be getting in the way of sleep, because obviously there's a link there with fatigue. So yeah.
I think Tony's got at least one question, maybe a couple from people online, so please let us know.
Actually, it was more a comment. The first one was, please can someone share the slide showing suggested book list? We will do that afterwards. We've used that before, some years ago as well. And in fact, I was chatting with Rob, and I mentioned it to Suzanne earlier. We're very keen to get a fact sheet on this, and I think what she's presented is brilliant. It's really, simple's the wrong word, it's really been clearly laid out, which raises the issues that everyone talks about. So thank you for that, and I'm sure we could use that as a basis.
Yeah, I think we've probably got a lot of information there that we could definitely put into a fact sheet. And, yeah.
And the comment here was exactly what you've reflected. Fatigue gets minimised, people can be very judgmental about it.
Absolutely.
That's the problem.
Yeah, absolutely.
And I make a little plea to everybody that this research project that we're doing about self-compassion, it's open to everybody with BEHÇET'S. We're very keen to have your involvement. It's a couple of simple questionnaires. It doesn't take very long. It's anonymous, isn't it? And it's just helping us understand a little bit about strategies and things. Rachel? Yeah. It's not just for England. One of the weird issues is that the Centres of Excellence are commissioned just for England, whereas we live in the United Kingdom, which is good. And I don't think the study is only for people in England, is it? It's Wales, Northern Ireland, Scotland. Yeah, I think that would be fine. And I think BEHÇET'S UK has been able to advertise the study. I'm not trying to give a cheap kind of commercial thing for it, but it's an important thing. We're looking at an important issue to do with BEHÇET'S. We really need your help in order to be able to know how you're feeling. And then when we come to analyse the results, there's a nice lad, Jim, who's the PhD student who's leading this. He'll be able to come and present to us. He doesn't know that yet, but he'll be presenting to us what his findings are. Time for one final quick question before Suzanne's allowed to escape. Yep.
There's a question here from Hayley. Do you think fatigue and ADHD can be managed together?
Ooh, that's an interesting one. Yeah, I mean, I guess that there's no reason they shouldn't be, but I suppose it's going back to that individual understanding of how, because ADHD can be so varied across from one individual to the next. It's not going to look the same. So I think it's trying to, again, in psychology, what we do is based on an assessment and a formulation, which is an understanding of that individual's symptoms and how they impact on that person's life. So that's, if in psychology, what we're aiming to do often is get that really thorough understanding of how it affects the individual, so that we can then plan interventions based on that. But yeah.
Brilliant. Thank you very much. Excellent.
Well, I think we can allow Suzanne in a second to escape. But the thing is, remember that at the three centres, we each have got our clinical psychologists. And one of the best things that we've done is been able to get somebody for each of the centres. So make sure whichever centre that you're affiliated to, if you are, you can access the clinical psychology. And Suzanne or her colleagues will have been there, seen it, done it, so don't worry about whatever you want to talk about. So you can escape back to your family now.
Thank you.
So thanks very much. The next speaker, which is the final speaker before we break again for coffee, is Dr. Mona Ghadiri-Sani. And Mona is a consultant neurologist, and she's the neurologist for the BEHÇET'S Centre in Liverpool. She's going to be telling us about another really important symptom that so many people suffer from with BEHÇET'S. Mona.
Thank you very much. Thank you very much to Prof and for inviting me today. So as Prof said, I'm one of the neurologists. I think we are a rare breed from what I hear. There aren't that many neurologists who are interested in BEHÇET'S. So I'm going to hopefully try to, if you don't know what the role of neurology is in BEHÇET'S, I'll try to kind of explain that a little bit. But majority of the talk is really about headaches in BEHÇET'S, because that really is the commonest thing that we see in our patients with BEHÇET'S disease. So what I do, I run a neuro-BEHÇET'S clinic along with Professor Moots. I work at the Walton Center, but we do the clinic at Aintree University Hospital, and we see patients from all over. So what is neurology? So neurology is the study of your nervous system. And your nervous system is anywhere from your brain, and it starts from the brain, goes down to the brain stem, goes down to your spine, and then nerves to feed into your arms and legs. So anywhere along that, unfortunately, Behçet's disease can affect. And as a result, you can have symptoms relating to that particular area. The commonest thing with neuro-Behçet's, so if you talk about neuro-Behçet's disease as it is, would be inflammation of the brain. But having said that, it being common, it's actually overall quite rare. So about 2% of patients with neuro-Behçet's, maximum to 10% of patients with Behçet's will have neuro-Behçet's disease. So overall, it's a very rare condition. But within that rare condition, if you were going to ask me what does Behçet's affect in my nervous system, the commonest thing would be headaches, number one, which we're going to concentrate on, and then after that, inflammation of the brain. And then we've got inflammation of other parts of the nervous system and all the way down to the nerves in your arms, your hands and your feet. So how do we investigate these patients? So if you come and tell me that you've got weakness down one side of your body, or you've got numbness down one side of your body, how would I investigate you? So I would need to do a scan to see if there is inflammation in the brain or in the spinal cord or any other parts. We can also do nerve tests, we can do bloods, and we can do a variety of other investigations depending on where the symptom is, what the symptom is. So the arrows are pointing to areas of inflammation. As I said already, it's not very common. So it affects only about 2 to 10% of patients with Behçet's disease. And we like it that way because when you do get it, it can be quite debilitating. It can present with, as I said, weakness and numbness and so on. So majority of the patients with Behçet's disease, however, do have headaches. And can I have a show of hands if anyone has headaches in this room? Very good. Excellent. So I would say it's about 40% of people in this room already have headaches. And what some people think is that migraine or headaches are just a headache. And that is not the case. And we know migraines, which is what majority of people with Behçet's disease suffer from, is far more than just a headache. We already heard about fatigue and cognitive difficulties. And actually, fatigue and cognitive difficulties are part of migraine as well. So you have the double whammy. You get the fatigue and cognitive difficulties from the fatigue side of things, but you also, if you have the headaches and the migraines, you get it from that side of things as well. So again, some people say, actually, no, I don't have headaches, so I don't have migraines. But do you have the rest of it? Do you get light sensitive? Do you get noise sensitive? Do you get smell sensitive? Do you get the fatigue? Do you get the restless legs? Do you get undeserved hangovers? Do you get, all the other symptoms which are outlined there? If you do, you probably do get migraines. Because as I say, migraine is a whole syndrome. Within it, you've got headaches, light sensitivity, noise sensitivity, so on and so forth. So it doesn't have to be just the headaches. Just because you don't get headaches doesn't mean you don't get migraine. You can still get migraines despite that. And it can be quite disabling because of the number of symptoms that are associated with it. So what we did, we looked at our cohort of patients that come to the clinic to see what proportion of patients have neuro-Behçet's and what proportion have the headaches. And what we found was that majority of patients actually coming to see us were coming to see us because of their migraines. There are other headache disorders in there, and one of them that you will see is the medication overuse headaches. And that's very important. You will see in later slides why that is important. But a lot of our patients, unfortunately, take painkillers because they have also joint pains, because they also have painful mouth ulcers, because they have genital ulcers. But unfortunately, that is the worst thing that you can do for the headaches. So that can make the headaches worse. And remember, we said it's not just the headaches we're dealing with here. So it can make the fatigue worse, it can make the light sensitivity worse, it can make the noise sensitivity worse, because it can make the migraines worse as a whole, and every symptom that goes with that. So when patients come to me and they tell me their headaches is the main cause of their disability, or is having a significant impact in their life, I say, why don't we try and manage your other pain disorders in another way rather than just giving you painkillers? Maybe physiotherapy, maybe acupuncture, maybe something else where we can manage the other pain and instead stop the painkillers, or at least reduce the painkillers. So let's concentrate on migraine. Why do I keep banging on about migraine? It's because it's one of the commonest conditions that we see anyway. I think we see it commonly in BEHÇET'S, but is that because it's common anyway and we see it as a result commonly in BEHÇET'S as well? Or is there, because there is some sort of inflammation within the nerves, as I already explained, there could be some inflammation within the nerves that's causing the migraines. We'll need to do some further studies. And even if we put BEHÇET'S aside, just migraines on their own can have a significant socioeconomic impact, because we know how debilitating migraines can be. When you have a bad headache, you can't concentrate, you're fatigued, you've got light and noise sensitive, you're irritable, you can't concentrate on your laptop, you can't work, you can't look after your kids. So even maybe your partner will be affected because they have to do some of the work that you would be doing ordinarily. So it's got implications for the rest of the family as well. It's not just for the individual. And this is again to say, it's not just a headache. Actually, migraines start days before the headache starts. So you're going to have prodromal symptoms. You know that feeling of thirsty or hungry that you get, or the yawning that you feel, oh, I must be tired, that's where I'm getting my migraine. It's actually the other way around. That thirst, that hunger, that yawning is a warning that something is about to happen. Your brain is warning you, a migraine is about to come. And then you can have visual symptoms, or numbness or tingling down one side of the body, or weakness down one side of the body, and that's your aura. And that can happen hours before the migraine. And then you go on to have the pain. And then with the pain comes everything else that we've already discussed. And then after you've been through all of that, your brain is being bombarded with all of that. Afterwards, you just feel, that's it, I've had enough. It's like patients say that you get, you feel hungover, you feel fatigued, you just feel that you've just been through the war, and you just, again, can't function for another day or so after that. So if you put the whole thing together, that takes about a week from the beginning to the end, and then you have the next attack, and then start all over again. And that's why it can be so debilitating, and that's why it's not just a headache. This is what I was explaining, that there is inflammation within the nerves. And that inflammation is not just for patients with BEHÇET'S. When we say inflammation, it's a little bit different to the inflammation that we see in the joints and other places and in the brain. But within the nerves, there are certain chemicals that make the nerves overactive. And as a result, the nerve is sending too much signals, too much light, too much noise, too much movement. One of those chemicals is this thing called CGRP. And we find in patients with migraines, there is too much of this chemical. And if you're going through a migraine attack, there is too much of this chemical. And guess what? If you're using caffeine and painkillers, there is too much of this chemical. So what we're doing with medication is trying to dampen down that nerve activity, but if you're taking caffeine and painkillers, you're increasing the levels of this chemical called CGRP, and hence things are not going to get better. And in fact, with painkillers, things will get worse. So we've decided that it's awful. It's awful to have migraines. Majority of us will have it. Even if we don't have the bond or everything pain, we've got at least some elements of it. So how do we manage it? The good news is there is a lot that we can do to try to improve the symptoms. And the GPs may not always be aware. So it is important, if your GP doesn't know what to do, direct them to the Walton Center headache pathway. They can just follow our pathway and manage your headaches better. We also have the headache information pack on our website that you can download and read about, and it will go through some of the information that I've just discussed with you. But there is plenty of treatments now for migraines, so there shouldn't be any excuse that your doctors are not treating your migraines. But what can you do? So it's very important that you take charge of your condition as you take charge with a chronic condition that you have, including the BEHÇET'S disease. So it's important that you have a healthy lifestyle. You exercise as much as you can. We don't want to overdo things and make the fatigue worse, but that little bit that you can, do continue to do that. And most importantly, avoid caffeine and painkillers. I think saying avoiding, stress, that's not realistic, but the things that you can do, try to do that. And we know that hormones are a major factor in migraines. So we will have fluctuation of hormone levels, and that will cause fluctuations of headaches. So if you've got menstrual migraines and perimenopausal period is another time when migraines get particularly worse because of that fluctuation of estrogen level. So it's important to be aware of that and to manage that appropriately. So there are many things that can make episodic migraine into chronic migraine, but remember, painkillers and caffeine are things that you can actually control and do something about and stop and reverse. So it's important to consider doing those things. So we're not just saying medication overuse headache because we want to, make your life a misery. You already are in pain with everything else that you've got with the joints and everything else. But the evidence is there, and obviously you live with your condition and you can decide what is the best treatment and what is, worst pain. Is it your joints? Is it your headache? And then you have to balance things out based on how you feel at the time and what is your most bothersome symptom at the time. And if you do stop painkillers, studies have shown that just by stopping painkillers alone, you will notice significant improvement in your headaches. So this is just painkillers alone if you stop it. But if you add a preventative medication, you can even reduce the frequency and severity further. So it's better to stop the medication, even just on its own is enough. But if you have a medication to help with the migraines, even better. You'll be happy to know that that's it from me. So what I'm hoping that I've got across to you is that migraine is very common, and migraine is common in BEHÇET'S as well, and that's proven based on our study and our audit that we've done. The best thing that you can do is, lifestyle modifications, stopping caffeine, stopping painkillers, regular exercise as much as you can, not overdoing things, and then your GP to help with your prevention and all the other things that we can do to help. If I have time, I was going to say when we talked about fatigue, as I said, fatigue is definitely part of migraine, but it's also important that there is a condition called restless leg syndrome. Now, restless leg syndrome, the way that works is, unfortunately, is caused by certain vitamin deficiencies in some patients, like iron deficiency, B12 deficiency, folic acid deficiency. And just by replacing those vitamins, the fatigue associated with the restless leg syndrome can improve. So if you're getting fatigue, it would be good to get your GP or us, if you see us, to do those bloods for you, just to make sure it's not something simple like that we can treat to improve your fatigue levels. So something simple can, and yes, there is a probiotic that I do recommend to all my migraine patients. You can get it from any health shop like Boots. It's called Migraine Probiotic. And it has all those things, including coenzyme A, which we already heard about. So it will have that, and it might be something that you may consider getting that will help with some of your symptoms, including migraine and fatigue. And that's it from me. Thank you very much.
That was brilliant, Mona. Thank you so much for that. Who would have thought that to cure your headache, you don't take a painkiller? But what a difference it can make, and that's really helpful to know. So Mona is going to be part of the medical panel a little bit later on today, so we won't take any questions. A couple of online questions have come through about headaches, and I've flagged those that we'll answer those live. So this is the end of this particular session. We're going to break for a little while for coffee, and then we're going to reconvene for 2 talks, one on oral health, particularly for children, one on for eye disease, a particularly important thing, and then you can grill us all on the medical panel after that. So coffee. Rachel, how long do we have for the coffee? 15 minutes. Enjoy.